Hello, and welcome back to this episode of This Healthy Life podcast. I'm so excited for my guest today. I have Shalin Shah, and he is a leader in metabolic health, and he specializes in testosterone replacement therapy. And he's also the founder of Chirotrex, a new oral testosterone. So this is a topic that is so important. It is such an epidemic that people are dealing with low testosterone, both men and women. So super excited to dive into this topic, have you share all your knowledge and what people can do to really optimize this.
Thank you for having me, Erica.
Yeah.
Excited to share with the audience.
Absolutely. So I'd love for you to start just with a little bit of your intro about yourself, some of your background, and how you got into working with testosterone.
Yep. So I've been doing this or working on Chirotrex for about 10 years now. It was actually in phase 2 clinical trials because Chirotrex is an FDA-approved drug. So it was actually phase 2 clinical trials. It was around the time FDA actually raised some concerns around testosterone regarding cardiovascular, and the space really kind of took a pause. And that's actually when I started looking at it from an investment perspective and peeled back the layers of the onion, really understood how important testosterone was for the body. And lo and behold, I got mine tested at the time and it was low, right? So then again, as you kind of explore your own health journey, you start figuring out and finding more and more and realizing how big, as you say, an epidemic this really is. And since then, again, a decade later, fast forward, got it approved by the FDA on our first shot, generated the best data in the space, and now we've started making Chirotrex available to the public.
Amazing. So let's start with some basics. So kind of just break down what testosterone is, what it does in our body, and why it's so important for us to have good levels of it.
Right. So testosterone is a hormone in your body. It is both a male and female hormone. So again, in terms of like societal like thoughts and whatnot, people really think about it as a male masculine hormone that's really associated with muscle building and sexual health. But the role is actually a lot broader. There is an androgen receptor on every organ in your body. And again, this is on the male and female side. So it's involved in numerous processes all the way down to cellular levels. And that's why it affects, mitochondrial health and your overall energy levels. And then all the way through bone, muscle, cognitive function, cardiovascular health. And again, the list really goes on and on. So there's this previous stigma around, especially, sports and steroids, right? Testosterone really gets labeled or cast in this bad light. But if you think about all of the roles that it plays, if it had a different name today, it would probably be the most sought after and valuable molecule in the world.
Wow. And so you refer to kind of this low testosterone epidemic as the silent epidemic. So what is going on with it? Why are people having such low testosterone levels? Like what's going on in our bodies or environment that's causing this?
So it's both, as you mentioned, your bodies and environment. And this is not just, in the last 1, 2, 3 years. This has been decade over decade. We've seen declines. And again, you're mainly checking male testosterone levels, but decade and decade declines in these levels. And again, lifestyle is certainly a large factor, right? If you track the rise of obesity, type 2 diabetes, cardiovascular disease, testosterone deficiency is right along those curves and actually increasing at a faster rate. So that is, again, from a sheer number perspective, in the US, there's probably 25 million men plus that are testosterone deficient. And that's growing because it's becoming a younger and younger issue. So it's not just, again, conceptually you'll think, okay, it's just old men, they're getting older.
It's going to drop anyways, right?
Exactly. But no, it's actually a lot more common in the younger male because again, lifestyle, but then you also have these environmental factors, right? Whether it's the water, it's in your water, in your food system, microplastics, you think about even fragrances and the result, what they do as endocrine disruptors, right? It's pretty much, you can reduce your own sort of environmental toxins to a certain degree, but there's so much that is honestly out of our control, right? And we're just exposed to it generation over generation. So it's just leading to these declines.
And then what about dietary impact? Is there like certain foods or diets that people are kind of like gearing towards more these days that are contributing to testosterone being on the lower side? Like, is it because we're eating more processed foods and have more obesity issues, or is that not a connection?
It's definitely, testosterone and obesity are comorbid, right? So low testosterone can lead to obesity and obesity can lead to low testosterone. So I think in itself, the processed foods are definitely driving a lot of this. I wouldn't say that there's necessarily, there are chemicals, again, there are toxins in there as well. So it's multi-factor within the food itself even.
Yeah, it's so crazy, right? Like so many things in our environment that people don't realize are affecting our health. And, you mentioned fragrances, which I think is such an important one because people don't realize, what that's doing to your hormones and like just your health overall. Like I heard an article or read an article the other day that it was saying that like indoor air quality is actually way worse than outdoor air quality. And it's because of our cleaning products, because of these fragrances and things that we're using in our home that are just disrupting our hormones.
Yeah, and it's everywhere. Again, you don't think about it, like all the years, right, of the chemical cleaning products, the air fresheners,
the Glade plugins, all those things, right?
Even your soap, right? Like, I'm getting a nice scented soap for my guests, but no, it's
super toxic.
Exactly. So we've gotten rid of all of that in our household.
Yeah, I do like essential oils only, or non-toxic or non-scented things to really try to clean that up. Air filters in every room. Hope for the best, right?
Yeah,
you can only control
you can
so
only
much.
do so much, right? And try and have these, good habits, but again, some of it's out of your control, and hence why, you really need to pay attention to it. And if you're deficient, these problems need to be addressed, right? Whether you're symptomatic or not.
Yeah, absolutely. So let's talk about some of the symptoms of low testosterone. So if someone is on the lower side, what are you experiencing? And what are kind of like those different thresholds of low testosterone? Like if you're really low, what sorts of things are you experiencing versus someone that might just be mildly low and not even know that they're low?
Right. So from a symptomatic perspective, often things that present the most common are things like fatigue, loss of muscle mass or inability to put on muscle, increased fat, especially like the adipose. Again, like testosterone deficiency is leading to some of that obesity. Your bone health. I mean, again, not everybody's obviously checking via DEXAs, but if you do check DEXAs, you're going to see decreased bone quality. Sexual health does suffer, right? So libido does suffer, and that's, at least on the male side, one of the reasons that they do get into the doctor relatively quickly, because
that's the leading symptom.
Exactly, right? There's not a lot of reasons for guys to go to the doctor.
I know you guys don't like going at all.
Right? So at least that gets them there. And honestly, it gives, and I think physicians should take advantage of that and actually start looking at comprehensive testing at that point, right? Because you finally got that patient in there, right? A lot of guys don't have primary care doctors. So maybe he finally presents in his late 30s or early 40s. Like, you got to grab him and run the full battery, because you just, they've not.
You don't know when they're going to be back, right?
Exactly. So those are some of the common symptoms that occur. And there's the threshold for low testosterone, hormones have a pretty wide range of what's considered normal or quote unquote normal. These levels have been also declining, again, decade over decade, that lower end. So it used to be 350 nanograms per deciliter. Then it moved to 300. Now it's in a lot of ranges 268. And these are often, what's unfortunate is, like, these are reflections of our population. Reference ranges are based on our population data. So yes, if we've had decades of testosterone declines, then this new range is going to be lower and lower. That is so far from
So they're
optimal.
moving the needle of what's normal based on people being chronically low, instead of keeping it there and realizing that we have an issue with
solve the
lower and lower
yeah,
testosterone.
Exactly. So more people are falling into this normal bucket. And again, what's unfortunate for a lot of folks that do present is they may get tested, and then traditional medicine, as I refer to, will just say, well, again, you're normal. So they'll brush it off, even though, let's use 300 as the cutoff. You might be a 301 that day, right? And like maybe the next day you would have been 299, right? Because you're going to see these fluctuations. And unfortunately, you're more than likely to just be told, hey, you're normal. Like,
even though you're one notch over.
Yeah, exactly, right? So that's unfortunate. And what's important is that each individual needs a level that's appropriate for them. So what we also encourage is, say, again, even as I mentioned, the epidemic starting earlier and earlier, but say you're a young, healthy male, like, you should get your testosterone checked and understand your baseline. Where are you when you're, say, 25? So when you're 35 and 40 and 45, you can track what's happening to your levels, right? So this way you really know, maybe, let's say I'm 1,000 nanograms per deciliter at 25, young, healthy, then maybe that's what I need, versus someone else, my friend, might be 700. Maybe that's what he needs, right? So there's that, and then there's also the concept of, free testosterone, and really what is the free testosterone that's in your body, because that's what's actually available to use, which, again, unfortunately, is not really tested as prevalently as it should be.
So let's talk a little bit about testing. So I'm glad you brought that up, because there's different types of markers for testosterone to check. And then, so what's kind of the go-to workup or lab work that you should be requesting from your doctor to really kind of test and get a full assessment of where your testosterone is at?
Good question. So naturally, again, total T is still going to be the big target, right? Just to broadly understand where this is. But as I mentioned, you really need to know your free testosterone. So as a patient, I would be pushing for a free testosterone. And often this is calculated even as well, which is fine. So it's relatively easy. But within that or beyond that, you'll have things like SHBG, which is the binding protein, which makes testosterone unusable and then kind of results in your free testosterone, right? So you want to know your SHBG. You often want to know even your estradiol, even in men, you want to understand where that level is. And then you often want to know your LH and FSH. These are the signaling that happens from the pituitary, which tells your body to make testosterone, right? So you want to know where those levels are as well, because as you're on therapy, again, depending on the modality, they do decline, some more than others. But again, it's important to just track as
make sure
a
everything's
metric.
kind of balancing out. And then what about for women? Do you recommend the same testing for women, or is it different for men versus women?
It's generally the same testing. I mean, again, also in the male testing, you'll have something like your PSA as like a safety check, and you also check your hematocrit. So your hematocrit being your red blood cells and the thickening that potentially could occur. Again, it happens mainly on injection therapy because of the dosing or the more common dosing that you see on that. And that's, again, more on the safety side too. If your hematocrit goes too high, then often you're going to donate blood, right? And again, that's, happy to talk about dosing and physiological. Like you need to really be like what's, I think, held back testosterone therapy a lot of these years is the side effect profile, mainly due to injections, has been a little challenging for both patients and providers. So the more we can manage side effects, and that's what we're seeing on the oral testosterone side, is just a relatively benign side effect profile. And then I think that makes it easier for patients to, be comfortable with therapy, but then also very much the providers to say, well, I'm not chasing all of these side effects, left and right and wondering if you went and donated blood because I'm concerned about it. And again, that's time out of your day, which you probably don't have. So again, a lot of these, I think that's been a big solve is for the side effect profile.
So let's talk a little bit about the side effects and some of the different ways to use testosterone too, right? So maybe let's dive into that one first. So there is injections, like you mentioned, there's the pellets, there's the gels, and then there's your new product, which is oral form, which is much easier. So maybe kind of break down the different pros and cons of each of those and why one's better than the other.
Sure. So injections are the dominant form today. They're relatively cheap, and then they've been used for a long time. So actually, I'll go a little bit further back and look at the timeline for testosterone. It was originally, so we've been using testosterone for almost 100 years, right? It was originally synthesized in 1935, and it was an oral form. The problem back then, it was liver toxic. So it was going through your first pass metabolism, and then again, it was toxic to the liver. So injections, sort of came out of that and have been used.
That.
Yeah, exactly. Because you're going straight into the bloodstream. That's the positive around injections, right? Like you will get that testosterone into your bloodstream. There's no two ways about it. I think the downsides are that you are often, because people are not injecting every day. A lot of these protocols started as like 2-week injections. Maybe they've moved to 1 week now, which is better than 2. But you're getting a super physiological dose to get you through that week, right? We kind of use the analogy that it's like waking up on Monday morning and having 10 cups of coffee for the entire week. The body doesn't work that way. Yeah. We make hormones on a daily basis. So how do you more closely match?
Sounds like a lot of highs and lows too, right? Like you're
very
getting
high,
a very high and then all of a sudden crashing
and very low
on this roller coaster constantly every week with the injections.
Exactly, right? So you would really want to ideally try and mirror your body's circadian as closely as possible. And then because of this general super physiological dosing, you're seeing things like the elevated hematocrits, you're seeing excess conversion to estrogen, you'll see the LH and FSH are totally undetectable, right? Because your body's saying, well, I got so much testosterone here, we don't need to do any work. Your factory is shut down completely. And that's why you actually see testicular atrophy, right? So that will also happen to men on mostly injectable therapy.
Wow.
So that's again, and I think
It's crazy that that's the most common form of it, right? And it has all these like potential issues,
all these side effects
that you
right?
have to deal
I mean,
with.
it's difficult, obviously, to manage all these things, but it kind of underscores how poor like the men's health like situation is, right? Because they're willing to do all of that to get back to themselves to a certain degree, right? So I think that also highlights, you know, the importance of finding a good solution for this, because it's not just one, you know, this is a huge problem, like 25 million people, right? So it's not just a niche thing or whatnot. This is really becoming bigger and bigger. So how do you solve this problem at scale, right? Gel sounded like a good idea. Those came out around 2000. Again, obviously not invasive, so nobody's having to inject themselves. The issue that comes around with gels is that you have a lot of absorption variability. So the skin is obviously different for everybody. So a lot of variability for people that are, a lot of people that are testosterone deficient are already overweight, and putting it on, say, adipose tissue, the adipose is more prone to convert testosterone to estrogen. So that also happens. You have transference issues. So once it's on, your spouse can't touch you, your children, even your pets, right? Like there's risks there. There's actually a black box warning on those products for transference.
Wow. How long does it take to kind of soak in before you
don't
have to worry about
34,
that?
But well, you're still almost constantly worried about, right? There's always this residual. But even in the application, like it's 30, 40 minutes of like just nothing, right? So you can't do anything and you have to let it absorb. And I don't know
who
how
has
that
time
would fit
for that
in your routine. Yeah, exactly. Like I need to put on my shirt and go.
Yeah.
Sit
around for 40 minutes.
Exactly. So again, it provided a easier entry, I think, for patients to conceptually to kind of get into, but it just ultimately it's not.
Doesn't really fit into people's lives.
Yeah, exactly. You mentioned pellets. So pellets are used out there, more common in female, I think, than males. The sort of going like similar to the injections, you're having this hormone effectively for levels for a very long period. Like pellets usually last 3-4 months. So there's no real set way to degrade at a rate that's physiologic, right? So again, you are getting larger spikes and then crashes, right? Except you're not having that crash at the end of the week, right? It's the end of your like 2 months or something, right? So like you have these periods where you feel great and then you don't feel great for a long time. And once they're in, they're in. You can't adjust the dose. So you also, you don't know if there are changes in your body and the way the body is sort of dissolving these things and whatnot. So that's there. They see the elevated hematocrit issue as well. And then, it's kind of like, it's not the best procedure, right? These are usually, inserted
invasive, right?
in the butt, and like there's scarring, there's extrusion, sometimes they come out and whatnot. The best thing is that like you could forget about it, right? You're like, I got it in here. I don't need to remind taking anything. So if you're really awful taking whether your supplements or your daily medications or whatnot, that is a nice plus, right? And then now we have oral, right? I think this is kind of the holy grail. Like if you think about it, every therapy, the most adhered to and used would be an oral medication, right? Patient preference, physician side, that's what we go to for, and even like in today's world, right? Like all the rage is the next generation GLP-1s that are going to be oral, right? I mean, obviously people have adopted to the injections because weight loss is incredibly important to, our society, but think about how many more people will actually start once there's an oral version.
Yeah,
exactly.
Absolutely.
So I think this is the same thing. So it's really kind of about awareness, education, right? Like both on why testosterone matters and why you should be, testing and understanding if you have an issue, but then also on the just the convenience perspective. But there are safety and efficacy differences too, which is nice, and we've seen these kind of start to play out very much so in the real world. I mentioned SHBG earlier, right? And SHBG levels have also been rising across the male population and the female population, but that oral and Kaisertrex is able to lower SHBG. Actually, so
in both men and women.
Well, we have the data on the men.
Okay.
So anything women is sort of anecdotal in that sense. But in our phase 3 trials, this came down by SHBG was reduced by about 30%.
Wow.
And we've seen
that's a hard one to shift to without with other things, right? Like that's one that
There's
doesn't really
nothing,
move the needle,
frankly,
nothing really that can help it.
To date, there's really been nothing that's been able to move SHBG down. Like people try like boron and supplements, but that doesn't, really help move the needle. So, free testosterone consequently in our phase 3 trials was up by 2 times. And in some of the real world abstracts that we've seen published by clinicians, it's anywhere from 2 to 4 times. So what's nice here is you're seeing a physiologic dose. So you're in sort of a normal range, upper normal range. You don't have to go super physiologic, but your free testosterone levels are sort of in line with what you might have if you were taking, say, an injection, right? And thus far, we haven't seen the body overcompensate. So like what happens again with injections is since you have so much exogenous testosterone, your SHBG actually just rises. Because it's saying, well, we got to counter this. There's too much going on. We need to buy, like they're going nuts, right?
So just making it even worse.
Exactly. So they're going and creating more to go bind to this. But that's the free testosterone is really where we think the future is, and people should pay the most attention to, and that's what's driving the symptomatic relief and the metabolic benefit at the end of the day.
Yeah. And then so say you do go down the route of doing, testosterone replacement therapy. Is that something that you're going to be on for the rest of your life to maintain those levels? Or does your body get to a point that you're like, hey, this is like the level I need to be at, and it kind of starts to relearn how to make the right amount for your body?
So it's typically a chronic therapy, right? You will typically be on it for life because, again, depending on the reasons why you're there, they might not be sort of fixable, right? So you may be on it. And plus, if you're getting the benefits of being on therapy, then like you should stay on it, right? I think there are a subset of patients that maybe have, maybe their testosterone deficiency was driven by obesity, and testosterone is going to help with, again, better muscle mass and better fat metabolism. So maybe you're gonna, and it's kind of like a virtuous cycle thing, to be honest, right? So if you get on this virtuous cycle and maybe you lose 10% of your body weight, and you're, you've changed the way that you eat, and you change the way that you exercise, and you change the way that you kind of get out and, get your sunlight, and your vitamin D levels are better, which are, these are precursors for hormones as well. It might normalize. There's a chance, right? So, and fully believe that should happen, and like people should try and like encourage this, right? Because even as much as, we're obviously in the hormone space, but foundationally, diet, sleep, stress, exercise, these are the most important things. These are the non-negotiables, and you got to do them. But just above that, yes, that's where your hormones lie, and they need to be addressed if they're out of whack. And those two bottom pieces of the pyramid, I think, are also our virtuous cycle, right? You're feeling better, you have the energy. Okay, you're going to put in the efforts. You see the efforts, you're going to keep doing them, and then the hormone levels get better, and it's a beautiful cycle.
If you have more energy, you're going to be working out more, building more muscle, and like everything starts to kind of align itself, right?
Exactly.
Absolutely.
So, I think those are sort of some of the benefits that we're starting to see. And again, on the safety side, things like elevated hematocrit. So less than 2% of our patients had an elevated hematocrit level. So it gives providers a different, just way of managing the patients, right? Because I mentioned on the injections, a number of the studies show almost a 66% rate of increased hematocrit, right? That's
crazy.
And that's when people sort of give up and they say, well, I don't want to do this because there's just too many things that are going out of whack. And then, what's interesting is we're also seeing LH and FSH stay in the normal range. They do go down, but stay at the lower end of normal. And that's we're actually doing, or one of the clinicians at Baylor, KOL, is actually doing a fertility study to look at, okay, with this new modality, are we able to maintain sperm counts?
I'm so glad you brought this up. This is actually one of my questions, because that's a big concern, right? Like if people are on testosterone therapy and you're trying to do fertility treatments or have a baby, that can really tank your sperm count. So how do you kind of navigate around that?
So historically and still to date, right, the advice is don't be on testosterone if you're, actively trying or want to maintain fertility, right? I think that's the most responsible statement that you can make, because we just don't have data that shows otherwise.
If you are on it and you stop, does it kind of reverse back and you get some of that fertility back, or
you
once
should.
you started, are you just kind of
no, it's not. I mean, from
you've rocked the
studies,
boat.
yeah, it's not like you've obliterated it and
Okay.
it has no sort of recourse,
Gotcha.
right? Technically, it should rebound. Again, like a lot of the not services in some sense, there's more options today. So I guess if you're a young male, like, and you need to be on testosterone, then maybe you sperm bank, right? Like you should just bank your sperm. It's so much easier today than it's ever been. So there are they're responsible things to do, or just easy things to do to maintain those. But yeah, again, so that is still there. I think there's this beginning of the research that's happening to examine it further. Because also if you look at look at fertility, like you have a fertility crisis in itself too with young men. And again, a lot of these young men have low testosterone. So it's trying to understand what exactly is that relationship too. And maybe you can, this is a complete hypothesis in some sense, but can you use so this is not a recommendation to use testosterone to try this by any means, but maybe you can, have low doses that help restore some fertility without knocking out, the sperm production as well, right?
And so why does that happen? What is kind of the connection there? Because you would think that if you have more testosterone, you're healthier, you have more vitality, it should make you healthier reproductively, right? So why is this kind of like hormone that's supporting that?
Historically, it's just that you have too much external testosterone. So you shut down your systems completely. So that's why it's interesting to see, if possible, if you take smaller doses in a pulsatile nature, right?
Gotcha.
You're just pinging instead of like flooding.
A big dose of it that your body doesn't know what to do with it. Gotcha.
Correct.
That makes sense.
Again, total exploratory, stage at this point, but I think it would be really, it's worth checking because I'm positive there are other therapies in development for, fertility and in males, but we have something. If this can work, it can be if it can be effective and relatively inexpensive, then I'd rather know what's tried and true to a certain degree, rather than a lot of these new molecules and what they do. We don't have long-term data for.
Absolutely. And then so if someone does do testosterone replacement therapy, what do you recommend kind of as like maintenance to be checking? Like how often should they be doing lab work? Like how often should they be kind of checking in, adjusting their dosages? What's a protocol like that look like?
Usually adjust doses when you start therapy, right? Like say it's 1 month, 2 month in, just to see how your body responds. Again, like with Kaisertrax, for example, you can check as soon as 7 days to see how your body's responding. But there's just variability in the sense that, I may be a normal responder and I work at the starting dose and then that's it. And there might be some folks that look exactly like me, but they are super responders and they need less. And there are people that are poor responders that need more, right? So because of that variability, again, you should, you want to check in month 1, month 2, so you can dial it in if needed and be on the right dose. Once you find the right dose, then again, this is up to your clinician ultimately, but you can move to probably at 3 months or 6 months, as long as your safety parameters are in line. Again, your clinician will guide this, but if your safety parameters are in line, then you're probably not going to adjust doses, and you can probably, space out your testing a little bit more. One thing that I hope we can move to in some sense, as there's more education awareness, is like we want to reduce the need for over testing. And I don't mean that like you don't want to know, but like I think guys are uber focused on the number, right? Like you talk to a lot of clinicians and how they present this to their patients once they get the labs. And what the problem is, sometimes the labs get mailed to the patients first these days, but you ask them, the good ones will always ask how they're feeling first. Right? Like, tell me how you're feeling, and then I'll tell you the number. Because if you do it reverse, it's going to impact. Like instantly, if it's lower than what they expected, they're going to be like,
I don't feel that good.
Yeah, exactly.
Yeah,
so
that makes sense.
So the number,
they got to play tricks, games, and a little bit of a game on them, right?
Because every guy's like, I want more. I want to be higher. Like they think it's all like higher equals better.
But higher's not always better, right?
Yeah, exactly.
Comes with a lot of problems. It sounds like if it gets too high.
Exactly. So I think that you really, if we can kind of focus a little bit less on that over time, again, as long as the safety parameters are good and those are being checked, then and the patient feels good, then
You
I
just
think we
go
can
off
kind
that.
of, exactly.
Yeah, absolutely. And then, so I want to switch gears a little bit. So I want to talk a little bit about kind of some of the common myths or like misconceptions around testosterone, right? So like, I feel like you kind of mentioned it a little bit. People always thought like, oh, it's for bodybuilders and, you know, men that just want to get big use it. But what are some other myths that you hear and kind of fears that people have about using testosterone that need to be debunked?
So two of the biggest ones are, one, that it causes heart attacks. Again, this started back in 13, 14, where there were a couple bad studies that were clearly not done properly, bad controls, etc. Actually, if you look at there was a citizens petition, and the FDA refuted and sort of laid out all the reasons why these studies were not adequate to sort of convey this risk. And that's been one of the biggest myths, both with patients and providers. The good thing is that because of that, the FDA mandated a study, that the industry conduct a study. This was 5,000 patients, randomized, placebo-controlled. And so this is the biggest study ever done on testosterone in this fashion, right? And it actually read out in June of 23. It's called the Traverse study. And it clearly showed there's no cardiovascular risk with testosterone therapy. I was like, flat out.
How'd they come up with that? Weird.
Yeah.
It was just bad science.
Yeah, it's just, again, it was honestly, it's not too dissimilar than, maybe not to the same magnitude, because I think this was worse. It was the Women's Health Initiative, which was totally botched and again, rushed out. They forced sort of the headlines, and it literally took an entire, I guess maybe probably 2 generations now of females off hormone therapy. There was, before the Women's Health Initiative, I think it was almost like 40% of menopausal women were on hormone therapy. That number is at like 2% today.
Wow.
4 years later. And now finally there's, this menopause movement that people are like, that they're speaking up and understanding.
To want to do it more and understand it better.
Sort of demanding like attention be paid to this, and which is absolutely right. So that's, again, we had the men had their mini event. So that's one of the biggest myths. And again, it takes almost a decade after the myth has been corrected to fully correct, right? So we're in 2023. So I hope it doesn't take till 2033.
Maybe less. Yeah. Now we have social media and the internet, right? Like people can move a little faster.
Better ways, but medicine still moves so slow.
Yeah, absolutely.
In that sense, which again, that's its own issue. Again, you have a lot of patients taking a lot more control of their health today than ever. So I do think it will move faster. Absolutely. I have no doubt about it. But that's really one of the biggest ones. And in a similar vein, it was also that testosterone causes prostate cancer. And that was even from a bad study in 1940. It's like 3 patients, 1 was a female, and then 2 were male. And these were older gentlemen, right? Like the rate of prostate cancer is high in older men, and 1 got prostate cancer. Like that's just,
that was probably going to happen anyway. Right? Yeah, it's like those are the odds as it is. So
exactly. And then that carried all the way through. And then you have a lot of urologists that are in that. I think it's not as bad as it was before. So I think it is understood that it doesn't cause it, but there's still this strange apprehension that exists around it, right? Even though the data is clear, even from the Traverse, they also looked at prostate cancer and equivocally as strong to say it doesn't cause prostate cancer. But again, I think there's just this general apprehension, and then
if medical providers haven't been educated on kind of like the updated stance on things too, right? Yeah. It's like you go to medical school, but you don't really stay up to date too much with.
It's really hard, right? They don't have time with all the information. How much time do you have to see patients? And actually, another big factor is liability, right? Like people, like a lot of providers, and I speak to so many. They're just like, I don't take any liability. Like, can I defend this? Can I defend this in court? And I've had so many providers say that to me, like, can I defend this in court, even though it's the right thing to do, and that's based on like science of today. Yeah,
it's frightening that that's how our medical practitioners are making decisions, right?
Exactly. Maybe they can give give more waivers, like inform and say, hey, look, this is what it is. But again, there's just no time in the traditional system.
Yeah, absolutely. That's sad. And then so let's talk a little bit about some of the early signs. So you mentioned kind of like what symptoms people will start experiencing when they have low testosterone, but what are some of those like first early signs that people can start to notice and be like, hey, maybe I need to get my levels checked? Or you mentioned like a lot of times men wait till the very end till they're having like sexual health issues, but What are some of those key early things that people can start to notice?
It's a gradual scale. So I do think it's difficult to detect early, which is actually why I think testing needs to be standardized in blood panels. So we have a nonprofit. It's called the Testosterone Project. We're actually advocating for blood testing across the board in every male over 40, because again, if you just like your cholesterol, right, like or your blood pressure or whatnot, you don't really notice these things. They're kind of flying under the radar, but they are obviously big flags and affecting your health, right? So if you just simply mandated testing, and the test is, testosterone test is like $10 or less. When you're talking about at scale and through the big lab companies, it's a very inexpensive test. So why not just screen for it? It's the best. If you actually think about it, your testosterone level is the single best marker of your overall health, because it gives you insight into your cardiovascular health. It gives you insight into say your like glucose metabolism and what's happening there, because it's an insulin sensitizer. It's gonna give you an insight into your inflammatory state, because the testosterone is anti-inflammatory. Again, you're gonna see your bone health, your muscle as an endocrine organ, right? So in some sense, it just, why would you not
good picture of everything?
Yeah, exactly. Yeah. So if it's a single best marker to test, like overall health, then how can it not be included in again, panels that seemingly tend to shrink more and more every year? And that's why a lot of patients have to go outside to get their blood work these days.
Yeah, absolutely. So let's talk a little bit about the future of where you see testosterone therapy kind of going. So what are some studies that you're super excited about, or some kind of different benefits that people are experiencing from getting their testosterone levels optimized?
So I think a couple of the interesting things are testosterone, especially considering what's going on in the GLP-1 space, is testosterone for muscle preservation with as an adjunct to GLP-1s. So that is a study that we're looking to partner on and carry out. I think it's a we expect it to be a decent outcome, right? Instead of using a lot of these other agents that people are trying to figure out, and big pharma is trying to discover, I think we have something here that can work very complementary. So again, just to put the data out there, I think will be very good. Something that we really want to explore, honestly, is like testosterone and depression. So some of the studies out there will basically look at, low depressive patients. I believe the stat is like 80% of them have low testosterone, right? It's very high.
That's crazy
rate. And then 20% will have major depressive, right? And that may say, and then there was the study went on to study, put them on TRT, and that 20% actually reduced to like 3%, right? On testosterone. And anecdotally, again, by no means like we are not indicated for this, and like not saying testosterone is not indicated for depression, neither is Kaisertrex, but like this is the research that we want to do, because we've seen such correlations.
Yeah, like what other benefits can you get from kind of optimizing your hormones, right?
Exactly. And think about how much, if patients don't have to be on SSRIs, and it was really just the hormones. So it goes back to the testing. Why not, maybe again, if you're presenting for depression, why not do a hormone panel? What's like,
that's not going to hurt, right?
What's the harm? Yeah, exactly. Yeah. And again, these are not expensive things. They're not going to cost the system money. It actually saves money in the long run, right? Because you're actually addressing the right problem, rather than like a pseudo Band-Aid that doesn't work, right? I mean, that's why you have so many, again, using depression as an example, you have like first line, second line, third line therapies that people have to go through and keep hopping through different meds and often not getting better, right? So that I think is an interesting place, or a meaningful place to go. And then it's female testosterone. Female testosterone, I think, is such an important prong, because when you look at, fine, it's estrogen, progesterone, but testosterone is the third part of that therapy for women's HRT. So I think more work just needs to be done, because there's no approved female testosterone. There never has been. There's only 4 countries in the world that have it.
Is there a future Kaisertrex for women coming in the works?
We are committed to working on it.
We need it too.
Yeah, absolutely. We're committed to working on it. I think we're encouraged by the new FDA and their view on female health. There was a panel done, I guess by the time this comes out, it'll be months ago, but and it was all focused on vaginal estrogen and female testosterone, and the FDA came out and talked about all the benefits that we're talking about here that they never have ever, verbalized, right? So I think that is incredibly encouraging for us to then continue to pursue something when we know we're not going to be, I don't know, maybe sandbagged is the best word, like, because that would happen under other scenarios potentially, right? So I think that's going to be a really, really big area and just something that's needed, right?
Absolutely. That's amazing. Yeah, definitely. So for me personally, I've had like low testosterone, like no matter what I do, doesn't get it up. My SHBH is like all over the place, right? Like super high, like never budges, never goes down. And I've tried like the creams. I just can't keep up with it, like the gels and stuff like that. So it's like having something like this that can really just kind of simplify your life, get you the right dose, make your life easier, and make you feel better, right? Because it's like, I'm sure I would be able to build more muscle if I had my testosterone levels optimized, and I struggle with that and like all these things, but there's not really like a clear guidance or path or like easy way to optimize that, right?
Yeah, it's hard. There's not a lot of solutions.
Yeah.
Again, the solutions are just not ideal, and they haven't been built for the female population.
And the science is way behind.
Exactly, science is way behind.
Like a lot needs to catch up.
Yeah, nobody's been doing it. But again, if we can get clear pathways, then Marius is absolutely committed to working on it.
Amazing. I'm looking forward to that. So we have time for one more question. So I kind of want to end on a more positive future note. And so where do you kind of see the next 5 to 10 years of like testosterone replacement therapy going? Like, are we going to be seeing like even easier ways to take it? Like obviously like oral is very easy, right? But like we're going to get it down to like a GLP-1, right? You take like one pill a week or one shot or pill a week, and that optimizes you for the week, help for women. Like where do you kind of see things going?
So what I see happening, and again, why we're sort of, so passionate and working on this every day is I think we figured out the modality, honestly, right? So, and I think being as close to that circadian rhythm is really what we want, even though I get the convenience of once a week, right? But like at the end of the day, if the benefit could be derived from doing it daily, then that's probably the right place to be, right? But actually what I think that we'll see is just a really strong awareness of what this is, right? Fixing the old stigma, understanding what this does in the body and how important it is. I often like equate it to vitamin D, right? So 20 years ago, nobody gave a hoot about vitamin D, right? And now everybody understands you need to have appropriate vitamin D levels because again, your health depends on it. But what's interesting is you don't have a clear set of like symptoms for vitamin D deficiency, right? And then if you look at from provider perspective, they really just say, look, you need to be above a certain level or you need to optimize it. They don't say like, these are the exact outcomes that you're going to see or anything like that. They're literally just like, look, you need to be in the normal range or you need to have an appropriate level of vitamin D for your overall health, period. End of conversation, right?
And they test you regularly for that too, right? Like that's something that's like
become like
more standard testing.
Exactly. So people are conscious of that. So I think that awareness and that sort of shift will happen because again, right now it's often the symptoms that people are addressing, which is absolutely appropriate. You address those symptoms, but the conversation in 5 years, or I think just the fact will be, you'll say, look, this is an important metabolic hormone. If you're deficient, you run the risk of X, Y, Z, and even more, and you need to be in appropriate levels. It's not a negotiation. This is what's going to lead to better, functional health at a foundational level, I should say, and they become non-negotiables. And I think that will do wonders for patients, for their outcomes and like disease prevention. And actually, honestly, it will do wonders for our healthcare system. I think we'll save lots of money in the long run if we can, again, incorporate this into preventive health. So that's 5-10 years.
Awesome. Well, hopefully that happens. So definitely looking forward to where this goes. And thank you so much for all this information. I think this is such an important topic that not enough people are talking about, addressing. Like you said, this really needs to become more kind of standardized in the next few years. So
absolutely. No, thanks for having me and helping share.
Awesome. So if people want to find you online and learn more about what you're working on, how can they find you?
So you can find me on Instagram at the Metabolic CEO. Kyzatrex is KYZATREX.com. And then I would also suggest rethinktestosterone.com. That's our disease awareness site. Tons of information, a lot about these studies. So you can dive into the studies, or you can get the fast facts, whichever you prefer.
Cliff notes.
Yeah, you get Cliff notes, exactly. So it's a great resource for patients and starting this, educational journey.
Awesome. And we're going to link to everything in the show notes as well. So thank you so much.
Awesome. Thanks for having me.
Thank you.